Afternoon, everyone. My name is Sacha Williams. I am a first-year master's thesis student in the Commissure Lab, supervised by Dr. Panaro and co-supervised by Dr. Trudeau. I'm happy to have the opportunity today to talk to you about my work entitled The Impact of Gender on Pediatric Surgical Care in Africa. So currently, 1.7 billion children globally lack access to safe, affordable, and timely surgical care. This suboptimal state of affairs is particularly felt in low and middle income countries, or LMICs, where children and adolescents make up a disproportionate fraction of the population. Moreover, recent estimates suggest that in these regions, the average distance traveled seeking care is 200 kilometers, with some children traveling as long as 5 days. In Africa, where the population is comprised of approximately 50% children, the surgical disease burden is quite significant. Yet surgical care is an aspect of child health that is often overlooked, despite surgery having the potential to prevent death and disability. Gender is a social construct that can vary by time period and/or society. It consists of characteristics, roles, and behaviors that are ascribed to perceived notions of masculinity and femininity. And although it may intersect with biological sex, we all know it's not the same thing, as the latter tends to focus more on biological factors such as chromosomes and reproductive organs. But it's important to note that historically, gender has played an important role in hierarchical imbalances of power, whereby within the male-female dichotomy, the female gender has been deemed inferior, along with other attributes denoting lesser intelligence, weakness, and lesser worth. So gender norms can be complex and multifactorial and can impact an individual's lifetime of health and well-being. For example, in certain African societies, gender inequalities have given rise to social and structural barriers negatively impacting females. This also appears to be reflected in recent reports that suggest that in certain African countries, women are less likely to seek care or seek aid for their surgical conditions, and that even when they do, they tend to have poorer outcomes. So that leads us to our research question. Are there gender disparities in pediatric surgical access and outcomes in Africa? The rationale for this work is the following. Gender disparities in access to global surgical care has been documented in the adult population. Yet, to date, pediatric surgical access and outcomes with respect to gender-specific differentials have yet to be elucidated for African children. So this study seeks to address the knowledge gap by exploring associations between gender, reported access, and postoperative outcomes. So our overall objective is to determine the impact of gender on pediatric surgical care in Africa. And we intend to do that by identifying whether gender disparities exist in access to care and whether there are gender-based differences in postoperative outcomes. Our hypotheses are that non-gender specific surgeries are performed more often on boys than girls, and that girls have a higher likelihood of poorer surgical outcomes. So before delving into the methodology, some important caveats, namely that since global registries and reports seldom use the term gender in the reporting, we'll be examining sex-based differences in access and clinical outcomes for multiple surgical conditions treated in Africa. Therefore, any deviations from predicted sex ratios will be attributed to gender. So the overview of our methodology, it's twofold. First, we'll investigate the Institute for Health Metrics and Evaluation's Global Burden of Disease database, and then conduct a systematic review and meta-analysis of pediatric surgical cohort studies disaggregated for sex. So honing in a bit on the first aspect, the GBD analysis, we'll interrogate the IHME's GBD database between 1990 and 2019 for pre-selected congenital and acquired surgical conditions with or known sex prevalence and severity. And then from there, case prevalence and disease burden by condition and sex will be analyzed by hypothesis testing. So a bit more about the second phase. That involves the systematic review of the sex disaggregated studies, basically harvested from multiple databases from inception through mid-2022. And then from there, prevalence and outcome means by sex for individual studies will be analyzed by random effects meta-analysis. This slide is just included to underscore the fact that the conducting of this study and its reporting will be done or is being done in accordance with PRISMA guidelines. So just delving into the systematic review in a bit more detail, the search strategy was performed by our senior medical librarian extraordinaire, Elena, and an extensive electronic literature search was conducted. The various databases explored are listed here, 8 in total, each with slightly different specializations, some focusing on a bit more on biomedical sciences, others on nursing, systematic reviews, Afrocentric material, and so on. So the search strategy involved text words from the title, keywords, subject headings, anything of that matter in order to yield papers focusing on pediatric surgery, gender inequality, and/or surgical care in Africa. So the resultant deduplicated abstracts were entered into RAN for independent screening by multiple reviewers for their pertinence or relevance to our study question. And then abstracts were placed into one of 3 categories. For example, included if the abstract met all of our screening criteria, maybe if it met at least one of our screening criteria with the potential of meeting the others upon full review of the text or of the entire paper, and then excluded, obviously, if it violated any of our screening criteria. So here are our inclusion criteria. We are looking at quantitative research papers written in English or French involving a pediatric population under 19 from an African setting, and work that includes data including sex or gender information, as well as access and outcomes information. So once the abstracts are screened and any conflicts resolved, then basically any that are flagged for inclusion or overlapping selections are then chosen for their full papers to be retrieved, and then the process begins all over again of the independent screening, conflict resolution, and so on. This is all done to yield a preliminary list of papers from which then we would mine the references through forward and backward searches for any further relevant papers to our study. And then all of that will be distilled down into a final selection list. Once that is done, we're able to then draft our PRISMA flowchart extract the data from our final list of papers, and then conduct the meta-analysis. So the proposed timeline for this work is divided by quarter. So the systematic review by the first quarter of this year, the GBD analysis by the second quarter, although now both are actually happening in concert, and then wrapping things up and writing it up by the third quarter of the year. In terms of next steps, we hope to take a mixed methods approach to identifying which factors can impact or be involved in gender equity in global pediatric surgical care via survey of local stakeholders. And from there, we hope then to be able to devise or propose a plan to augment gender equity in the field via focus groups with relevant stakeholders. So in conclusion, non-existent or inadequate care can have devastating effects on child health. And this may be impacted by gender inequity. So through this study, we intend to shed some much needed light on both this sensitive issue, but also on this vulnerable population. And that's everything. So